Ready?
I can hardly watch it. It's so.
Good evening. Welcome to the October 21st meeting of the Los Angeles City Health Commission. I apologize for being a little bit late. There was some downtown activity that prevented some individuals to get into the City Hall. If we could have a roll call, please.
Yes, Commissioner Avila is absent. Commissioner Cohen is absent. Commissioner Hisarick.
Here.
Commissioner Ho is absent. Commissioner Cato.
Here.
Commissioner Kalfani. Here. Commissioner Lemus has not arrived. Commissioner Mandel.
Present.
Commissioner Osi is absent. Commissioner Shannon is absent. We do not have a quorum.
When Commissioner Lemus, actually Dr. Lemus comes here, we can then have a quorum and do the other business. But in the meantime, there's a question for the city attorney, actually. Can we do public comment temporarily? Or should we wait for Commissioner Lemus?
Until a meeting is officially convened by way of a quorum, then public comment does not constitute public comment for purposes of the meeting. So should you hear from anyone who then, when the full quorum is present, then they would be able to speak again.
Okay, so then what we'll do is we'll wait for oh. Hey.
And
For the record, Dr. Lemus just arrived, so now we do have a quorum. With the roll call being done, I'd ask for a approval of the minutes of the September meeting.
September
I'll move
9th.
to approve. All in favor?
Aye.
Anybody opposed or abstaining? Unanimous. One aspect of importance from the September meeting, not that occurred then, but we received a letter talking about the public comment of that meeting, which we'll have read into today's record. Please.
Dated October 17, 2024. Dear Los Angeles City Health Commission, the current policy restricting public comment to in-person attendees is discriminatory, ableist, and prevents participation by housebound or other disabled citizens. Public meetings should be fully accessible to all Angelenos regardless of ability to attend in person. Remote options are equitable, particularly in a city with about 1 million residents with long COVID, a severe and growing public health crisis that the Commission has completely ignored. During last month's presentations by Dr. Cannon and Hudson, you discussed your own recent COVID infections and the value of wastewater data, but didn't address mitigations. Detailing these realities without commensurate response is a glaring contradiction. This dissonance reflects poorly on your leadership and undermines your expertise in public health. Updating to the new normal of remote meetings is just one way the City Commission should respond to the ongoing pandemic. For example, the LA County Public Health Commission quickly standardized this in their meetings. Asking people to request ADA accommodations isn't practical or equitable and further marginalizes them. The Commission neglects its duty to, quote, accurately determine the health needs of the people of the City of Los Angeles, end quote, by limiting engagement and ignoring COVID's pervasive impact. Please respond accordingly to your responsibilities in Ordinance Number 183093. Thanks for your attention. We look forward to a prompt resolution by the November meeting. Sincerely, Sarah Johnson and others.
So 3 points. One is that there's erroneous statements in that letter. One is there are not 1 million people with long COVID in the city of Los Angeles. That is a created number. I'm not sure where Ms. Johnson got that information, but it's not accurate. Two is that we have no control over the aspects of virtual public comment. That is something up for the city council. It is out of our purview, it's out of our control, and it's not consistent with city law. The third is in her long letter, She also sent copies to numerous members of the LA County Department of Health, including their entire leadership, which thereby recognizes that she's not totally aware of our role as a city commission, which doesn't answer to and or advise the county officials. So she needs to be educated about that. I wish there could be more Zoom meetings. I wish there could be public comment virtually, personally, but that is out of my control. It's up to the city council. We have no role in changing that. We have no ability to change that. We have in our previous reports to the city council requested the ability to be both live as well as virtual or hybrid. Those recommendations have been made from this commission to the city council on several occasions, and I would publicly say that I would love to see that happen again. It would allow us to have experts from Europe, Asia, or from the East Coast of the United States present as we did during the years that we were totally virtual. Having said that, is there anybody from the neighborhood council here for comment or discussion? Seeing none, is there anybody for public comment? No. All right. With that, Dr. Heisinger, you can come up to the main table. It is a great pleasure to introduce Dr. Robert Heisinger, who is Associate Professor of Clinical Medicine at the University of California, Los Angeles. He's a recognized national expert on sexual health, sports medicine, obesity-related disease, and he has served as an expert witness in multiple high-profile trials, including the O.J. Simpson criminal and civil trials. He has also appeared regularly on 30 national TV shows, mentioning several of them: Extreme Makeover, American Gladiators, The Biggest Loser for 17 seasons, most recently Strong and Ultimate Expedition. He's written several books, including Sex, Lies, and STDs. He has also authored Where Did All the Fat Go? And You're Okay, It's Just a Bruise. And he has co-written a screenplay with Oliver Stone, Any Given Sunday. He has over 25 medical journal publications and abstracts on work with medical prevention. He's presenting and treating increased numbers of sexually transmitted infections in the city and county of Los Angeles. We're here to be educated by him as well as action based upon his recommendations. Dr. Heisinger, it's an honor and pleasure to invite you to speak to the LA City Commission. You should be aware sometimes we're videotaped, tonight we're not, but we are live audio to the entire public on the city channel.
Well, I want to thank you for having me here.
Bring your mic all the way up.
Okay.
You can pull the mic to you.
Usually I yell loud enough so I don't need a microphone. Tonight I'm going to talk about sex, lies, and STDs. This was a subject that I became very interested in when I had a patient who came out with his diagnosis of HIV, and the amount of virile misconceptions about that particular STD shocked me so much that I started writing about his issues, and then all the other STDs. I realized the mass amount of misinformation and, very frankly, ignorance. And I'd like to go over some of those things tonight, but let's just start by, I always think when I'm talking about STDs, it reminds me of that famous Tale of Two Cities opening line. It was the best of times, it was the worst of times. So for the best of times, we have unprecedented new scientific advances in the field of sexually transmitted diseases. We can readily diagnose and treat diseases that have plagued mankind since the beginning of recorded time. Chlamydia has been here since the very earliest recordings in Greek and Egyptian history, and syphilis, something that we actually got from North America. It was transferred to Europe and essentially was so widespread that before World War II, it was estimated at least 10 to 15% of Americans had syphilis as recently as the 1940s. So this is something that caused untold destruction. And then we have these new diseases that have probably been there forever: chlamydia, mycoplasma, and hepatitis C, but we now have the means to diagnose them. And then for the viral, we have these deadly viral infections. HIV, when I was an intern, 1979, we had a disease that was killing literally tens, hundreds, thousands of people in front of our eyes. We had no diagnosis for it, and we had no idea how it was transmitted. And that's why some of us back in that day, are interested in COVID. Like, we had something that was just far, far more worrisome. But with our hard work, with perseverance, we went from that 1979 doom situation to finally a test in 1985 came through to diagnose it effectively. We had additional confirmatory better tests in 1987, and then finally, in the early 1990s, there became multiple groups of therapies, when used together, became very effective in finally reducing the death and giving these individuals hope. More recently, and this is part of the reason I wrote this book, in 2015, something unthinkable happened in my mind, because we were used to the horror of HIV. In 2015, if you were an individual with HIV and you were fully treated, you could have relationships with other individuals HIV negative with a 0% chance of transmitting. So you went from something that was 100% death, or 99% over a very short period of 10 years, to a situation where you were able to not pass it on if you were fully treated. The problem is, and these are what we're going to go through, we still have tens of thousands of people diagnosed with these diseases, specifically HIV, and many of them unaware or getting improper treatment. And so that's why when we go to the next slide, these innovative measures are falling on deaf ears. Here in Los Angeles, we're smack dab in the middle of a raging STD epidemic. We have, significant increases in gonorrhea, maybe a 200+% increase over the last 10 years. We have chlamydia that's gone up 120%. We have syphilis that's gone up, practically 300%. And the saddest of all, congenital syphilis. When a mom delivers a baby and passes the syphilis onto the child, this is something that's going up at the rate of 600% over the last 4 years pre-COVID, and something like 22-fold, which is 2200% increase in a disease that we had completely eradicated almost in the 1950s. So it's very sad. We have the technology to diagnose. We have the technology to treat completely in many of these instances, including syphilis. But we've got to have the motivation to make it happen. Now, why in the world in 2024 do we have these increases in gonorrhea, chlamydia, and syphilis? Well, there's a huge, vast numbers of cases out there, and we have to get through those. So, how many people are going to catch an STD in America this year? If you look at the bacterial ones, almost 100,000 individuals are going to catch syphilis this year in America. There's going to be over 100,000 lice cases caught this year in America. We're going to have almost 1 million cases of gonorrhea, over 1 million cases of trich, over 3 million cases of mycoplasma this year in this country, and chlamydia will be the most common bacterial infection, nearly 3 million. And this is sad, something that hopefully we'll have time to talk about at the end. Disadvantaged populations, women are at increased risk of some of these diseases, and younger individuals as well, more susceptible to some of the harms of chlamydia, which, besides the obvious infertility, include death. If you get, as Dr. Mandel will tell you, if you have a pregnancy and it gets stuck in the tube because you've got scar tissue, 150, 200 women die every year in America from that sort of a problem, and that's all preventable. Those deaths are not huge numerically, but they're so tragic because they're preventable. So in the viruses, we have something like 31,000 Americans are going to catch hepatitis C this year. 20,000 are going to catch hepatitis B. About 38,000, possibly less, because HIV is one of those STDs that is decreasing in the face of multiple others increasing. Somewhere between 32 and 38,000 Americans will catch HIV this year. And the more frequent ones, 3 million Americans will catch herpes, something that hopefully we'll get to talk about more later, and something like 14 million will catch HPV. So the background of that, why so many Americans can catch it, look at how many, that's the incidence, how many new cases. Well, how many permanent cases? How many Americans sitting at home have an infectious STD? This shocked me because I just did another TV show that was going to be a national show, and they wanted me to come in, and they had all the lawyers involved because there were going to, possibly be some individuals on this TV show hooking up. So they wanted to make sure no one got an STD. So we examined in detail over 70 contestants for this show, and shockingly, about 70% had a communicable STD. These were incredibly attractive individuals that were picked out for a variety of reasons because of their success in life. And of the 60%, 70% that had an STD, probably 2/3 had no idea. They were angry. Why? Because their doctors told them, we're doing a complete STD check, incorrect. And often because their doctors told them we're doing a complete STD check and didn't even run certain of the tests. So we have a huge problem. We have incredible, unfortunately, ignorance and head in the sand phenomenon from Americans, and then we have some of that same phenomenon among our doctors. So part of it is people go, gosh, STDs are so scary if you start talking about it, but they're not scary at all. They're very straightforward, and if we protect ourselves, if we do what we can, they actually are no big deal. They're actually no big deal. We have a couple that are tough, HIV being one of them, but we've got incredible prevention for that. And we've got things to do for other permanent viruses like herpes if people want to pay attention. So what's scary is ignorance and inaction. So let's go to what we're all here for, and that's eliminating STDs completely. Well, obviously, as I've implied several times, it's got to start with education. So here are just a couple questions that, very few individuals and unfortunately not that many doctors understand. Number one, how do STDs present? How do you know if you've got an STD brewing? Number two, what's the effectiveness of condoms and other prevention? Number three, well, what sexually transmitted diseases should we test for? And lastly, when should we test for those STDs? If we just knew the answer to those couple of questions, we'd be so far ahead and be able to get at this problem where literally we have 150 plus or minus Americans sitting at home today with an infectious sexually transmitted disease that we're not doing anything about. We're happy to give everyone in the world the COVID test. And we won't even talk about currently what COVID can and can't do, but we're incredibly resistant to come out with the test for these completely treatable STDs that can wreak havoc on the health. So let's start with the first one. And without embarrassing anybody, you know, what's the most common initial presentation of a sexually transmitted disease? I can tell you that when I wrote this book, because of everything I went through with Charlie Sheen, I thought, gosh, which college kid, which young individual that was sexually active wouldn't want to read about every single disease and what they could do to prevent it? But nobody wants a book with sex and sexually transmitted disease written on the cover. And people are under this incredible false idea that if they get a sexually transmitted disease, something will happen to them. They'll get some sign and they can run to the doctor or run to the internet. So what is it? Is it urinary symptoms? Is it, you know, the urge to urinate? Is it pain on urination? Is it discharge? Or is the symptom vaginal discharge? And the type of vaginal discharge? Or is the symptom rectal pain or rectal discharge? Or is the symptom you're going to look for genital sores? So what is it? What are you going to look for that's going to tell you you have an STD? So here's the answer that even doctors don't understand. The most common presentation for a sexually transmitted disease is, drum roll, nothing. You've got a couple. You've got lice, almost uniformly presents with itching. So that one, you don't need a doctor. You itch, you go, oh, something's wrong. You can look that one up. Another one is gonorrhea. The majority of men, probably 60%, have a discharge, have a urethral discharge. Every other STD, the majority, some present with symptoms, but the majority present with nothing. For example, herpes. 80 to 90% of people present with no symptoms. Oh, if you really educate the country, you could get 50% and you'll teach them very mild symptoms that really indicate they have herpes. But even with the best education, 50 to 60% of people never will have the symptoms from herpes, and maybe 40, but only 10% will have an obvious symptom. This is what we're dealing with. But we can treat it, we can do something, we can prevent it, but not if you want to have your head in the sand and you don't want to test or you don't want to do full testing. Next question, condom effectiveness. What do you think the condom effectiveness is for the STDs? Let's go through some of them. I think people are shocked when they realize that, if I can get to the right slide here, people are shocked when you go through the list and you go HPV. Condoms are only 50% effective for HPV. Why? Because a condom covers a certain portion of the male's penis. But HPV is a virus that goes through skin. So it covers part of the skin and it's partially effective for treating it. But it's 50% effective. And if you go through all the skin-to-skin diseases, that's herpes, skin-to-skin. That would include syphilis, that's skin-to-skin. Obviously, pubic lice doesn't have any protection from that. And oral herpes, herpes type 1, mouth-to-mouth, that's a sexually transmitted disease. That also isn't going to be helped by condoms. So when you then factor in what we just showed, that slide, with the current prevalence of all the STDs, and I said there's 150 to 160 million people in the country with STDs, on average, a condom, when used the way condoms are used, and they're used horribly because they only protect pregnancy 80 to 85%, so they only protect these other things 80 to 85% at best, and the skin-to-skin ones much less. So you've got about 59, 58, 60% protection from condoms. So that's better than nothing, but we have to combine condoms with multiple other forms of protection. It's not a standalone great thing. Now, obviously, one of the other things we'll talk about, we need to teach people how to use condoms, but this is what we're dealing with today with, you know, the current situation. So the next thing that we talk about is, well, let's first talk about what is a complete STD evaluation. Well, it turns out that that should be all the things that are relatively common that can have bad consequences, that can cause infertility, that can cause different symptoms that might go on to cause other disease processes. And, you know, when we do that, we recognize not many doctors check for HPV. Obviously, gynecologists do when they do pap smears, and gynecologists do when they do HPV cervical tests, but not many doctors, look at other areas, including the rectum and the mouth, which also, are susceptible to HPV infection. Doctors also tend not to do herpes tests. They tend to do that because up until literally a couple decades ago, it was very difficult to interpret herpes. And that's one of these amazing new advances. We now have accurate tests that can differentiate between herpes type 1 and type 2, which we didn't have before. And we also have better prevention for herpes. We need a lot of research on that. We need to get a vaccine, and we need to do a study on pre-exposure herpes treatment, the possibility of using Valtrex before exposure. The other test that's not done, because we really didn't have a test until relatively recently, is mycoplasma. Mycoplasma is a bacterial infection that doesn't cause as much symptomatology and doesn't cause as much problems with a woman's womb and with her tubes, but it clearly does cause, we're now finding out, infertility. And we now, literally within the last handful of years, have these new genetic DNA tests to accurately diagnose it. And sometimes it doesn't go away with the treatment for some of these other diseases like chlamydia and gonorrhea. And so that's something else that we need to test because it's very common and it can cause problems. So the next thing is, okay, when do we do testing? As you can imagine, as doctors, and Dr. Mandel can second this, we see people coming in the day after and go, oh my gosh, I had this encounter or that encounter, you got to test me, from yesterday. But the tests don't turn positive very quickly. And in fact, when we look at the very fastest tests to turn positive, they tend to be some of these genetic tests. A genetic test, to give you the short code, detects the pathogen. It detects the infection, whereas antibody tests, your body's got to take some time to recognize you have an infection and to react to it. And so even our best genetic tests take a week to 2 weeks, and in some cases even 3 weeks to turn positive. So for someone to do a full screen before 3 to 4 weeks is really pointless, and many people are not aware of that. And they're also not aware of the difference between and the timing of when an antibody test turns positive versus a genetic test. So more on education. People need to know more about the law and sexually transmitted disease. I mean, people still think, that they can put an antibiotic in their partner's drink, if there's exposure. People still think that, they can, they still think that they're going to spend a lot of time getting a partner, but a casual partner, they're not going to put any time or thought into that in terms of their chance of having any of these ongoing infections. And the other thing is people always want to do testing afterward. They don't think beforehand. And I think one of the things we should be emphasizing is that, people should go together to get STD checks when people have relationships that are starting, because it does several things. Number one, it educates people, which I think is important. And number two, I think it's kind of a very good contract that both partners have talked about their sexually transmitted diseases. And it's not a consent for intercourse, but it is a consent that we have discussed things, because that's something that we also see is people are obviously very upset when they have certain diseases that accrue. But I think we all have to take responsibility if we don't look and try to understand this beforehand. And that is basically both parties have to do testing, never do testing on just one party. And they have to understand the window period. You can't do testing and think that you're safe, because that's something that takes, as we said, at least 4 weeks. In some instances, like hepatitis C, could be up to 3 months. There is a lot of confusion about the use of condoms, and what in fact is an oil-based product that obviously degrades the condom and makes the spaces open so certain infections can happen, increases the risk that the condoms do not stay on. There's several condom types that do better in terms of remaining in place, which is something that we need to pass on as well. And then there's a lot of new exciting stuff about what we can do after intercourse in terms of post-exposure medication, and that includes for high-risk HIV exposure and high-risk chlamydia and syphilis exposure. There are drugs to prevent HIV taken before exposure as well as after exposure, depending on the timing and the level of perceived risk. Chlamydia and syphilis, likewise, you could take a certain course of tetracycline either before or in certain cases afterward in high-risk chlamydia and syphilis. One of the reasons for this new epidemic where chlamydia, gonorrhea, and syphilis are increasing is that individuals are using condoms less. High school kids, 10 years ago, it used to be in the 60 to 70% range. Now it's down in the 40% range or so. And obviously, individuals at risk for HIV are no longer using condoms because we have medication that can make it very difficult, 99% protection if you take it beforehand, even if you're exposed to somebody with HIV. And if your partner has HIV fully treated, probably that's 100%. We think that STD testing, of course, is needed if there's any suspicious symptoms or if individuals have multiple partners, whether there are men who have sex with men or heterosexuals. And this is something that, should be done every 3 months. And it's sad that people at high risk tend to do checks every 1 to 2 years when they should be doing it every 3 months. People at moderate risk that should be doing it once a year are doing it more like 2 or every 3 years. Obviously, another thing that's new that I was always unaware of, if you have an individual with an STD, a lot of doctors want that person to get in their face with their own doctor, but that just doesn't work. And so now we have the option legally that when I see a patient with a sexually transmitted disease, I can give them one other course of treatment or 2 or 3 or whatever's needed for their partners over that period of time that they were exposing. And that is a marked improvement in treatment that we never had the option to do. And that's something that we're doing a little bit more. Other things that we wanted to talk about were, when I was writing this book, I'm not the world's expert. I went to Harvard. I thought I knew my stuff, but there were many questions I could not find. I could not find the answers on the internet. I could not find the answers in the library, in medical. I had to get a co-author, one of the head infectious disease doctors in this field, Jeffrey Klausner, because there's so much stuff even doctors don't have access to. And so one of the things I'm most proud of, and nobody can read that, we always laugh at these slides in medical lectures because it just means give up. There's no way to understand this. But what this is and why I'm so proud of it, and I put it in here anyway, is I've listed here, and this was mostly Jeffrey Klausner and massive amount of research, every different sexually transmitted disease, and then every different route of sexual transmission, whether it's penis to vagina, vagina to penis, penis to throat, penis to anus, and what exactly is the known risk of each sort of sexual exposure. And I think everybody needs to know these numbers. We start out with something like hepatitis C that basically is the least transmissible of all these, and then you get HIV, which is approximately 10-fold more infectious. And then you go to something like HPV, or even something like hepatitis B, which is 10-fold more infectious than HIV. And then you go to these bacterial infections, chlamydia, gonorrhea, trichomonas, which are 10-fold more infectious than the hepatitis B. And you can see that people, I think, can understand a little bit more about what to expect and and what's the level of importance about prevention when they can understand their exact risk per sexual act. There's also, I just put in here many other charts in here about things I never knew, and I wanted to know which STDs can you catch with oral sex. Probably not HIV, but definitely HPV and chlamydia are at the top of the list. Which STDs are transmissible with sex toys? Yes, HPV. Yes, all the bacterial things. Probably not hepatitis C. Probably not lice. Those things I think also help bring people on board when they understand kind of all the nuance of this. I really think that that's helped. So back to prevention. To me, I would like to throw out to this group that we should provide free condoms in schools. I think we should also teach kids how to properly use condoms. You know, there are some states that have no sexual education, such as Utah. I'm very much against that, but I think we need a strong educational push to reveal all these details of sex. And once people understand it, I think they'll take a much more proactive role in preventing it. I think we need a really strong educational push. I'm totally against mandating vaccines, but we need a strong educational push for HPV vaccination prior to 7th grade entry. HPV, as some of you know, has passed HIV in terms of the number of deaths. HIV, approximately 6,000 deaths in America. HPV, approximately 15,000 deaths. You've got cervical cancer and many cervical procedures and possibly complications from that. And you've got oral cancers, and we're still doing research. We don't know if there's other squamous cancers of the esophagus and even lung that are caused by HPV, and certainly a large number of oral cancers. So you've probably got 40 to 50,000 cancers a year and 15,000 deaths from this virus. And for us not to vaccinate there and to mandate meningococcal vaccines for colleges, well, I think that's important because there's probably 200 college kids die every year from meningococcus, but we're talking here 15,000 a year. It's orders of magnitude different. So we need a huge push for HPV vaccination. I also believe that we need to recommend doxycycline prophylaxis in individuals with high risk intercourse, men who have sex with men, men and women who are heterosexual, who have multiple partners per year. And I think we really need to study Valtrex because I think there may be a role there to work within the whole realm, including notification, which lowers herpes spread by 50%, Valtrex, which lowers it by 50% if the person that has it takes it, and knowing really clearly when you have outbreaks. But we now clearly know the majority of herpes is spread in individuals in between outbreaks. And so we need, once we notify people of that, they become much more vigilant in taking some of these antiviral preventions. I think that since we've got this huge group, 150 million, that have sex disease, or this huge group of up to 25 million people getting it a year, we need to declare a month as STD month and just go through and test everyone. We kind of did it with COVID, and I think this would leave much more bang to our buck for going after this group of diseases. I think we need some same-day testing that's available, especially to high school and college age kids, and we need to also really work hard on affordable home testing for these diseases. And we really need to re-educate doctors as well, especially on screening these vulnerable populations that have chlamydia, 3 million, especially young women, and then these women that have babies and go to term with syphilis. It's unacceptable. And then treatment. As I said, we now have the wherewithal to, once we identify a case, to let that individual go out and treat their contacts. And I think that's a very, very successful approach. But if we treat, we will essentially eliminate chlamydia, mycoplasma, gonorrhea, syphilis, trichomonas, and pubic lice. And I think we'll markedly decrease the rate of HIV, hepatitis C, and to a lesser extent, the herpes virus. Research is important. We really need to invest in syphilis because we've got to be able to get rid of that. We really have the manpower. We've got all the knowledge to make that happen. We need a vaccine for gonorrhea and chlamydia. We need antibiotic research for the new scare that we have in medicine, completely resistant gonorrhea. As you know, we used to treat it with penicillin and then got resistant to that, and we treated it with sulfa, got resistant to that, then we treated it with the Cipro-like drugs, it got resistant to that, then we decided, oh, we'll treat it with 2 different drugs together. That worked really well, ceftriaxone and tetracycline, and then now we have some resistance emerging to that. So that's something else, and we've got to accelerate our research on the herpes vaccine. I'm a big believer that we need to legalize sex work. We need physician and patient notification, of past partners when STDs are identified. And as you know, the public health system has been pretty gutted in the recent past, and we have to do whatever we can to rebuild that. And if there's any time, I just would like to mention this special thing with minorities and women suffering most. Because of the anatomy of women having more exposed mucous membrane, genital mucous membrane than men, they tend to be much more susceptible to these diseases. Men tend to pass it much more. Men pass these diseases at twice the rate that women do, but women have twice the rate. Women are harder to diagnose because of the anatomy as well. So the women suffer a higher chance of inappropriately misdiagnoses, and their risk of infertility, maybe up to 24,000 women a year, as compared to a relatively rare instance of this in men. And women and minorities are also, in sometimes vulnerable positions with more difficulty refusing unsafe sex or the situations that they're presented with. And so we have to somehow also figure out how to demand safer alternatives and make consensual sexual relations safer. Thank you very much.
Thank you for a wonderful overview of everything you ever didn't want to know about STIs. Just a couple questions, and I'll open up to the commissioners. There's probably 187 subtypes of HPV that are prevalent in society, just like the COVID virus. They mutate, they change. HPV a little slower, a little less, but the significant number. We've created an excellent vaccine, but it only covers 9 of the subtypes. So we know that there's 7 other subtypes that can cause different malignancies. So even if we vaccinate large percentages of patients, there's still going to be some patients who are still going to be susceptible to getting precancerous lesions. What would you recommend for us to do as a society? Do you think we should create a more expansive vaccine that covers all the 14 subtypes that cause different malignancies, or do you think that because the other ones can be picked up with colposcopy and pap smears, just encourage women to go to the doctor more?
A couple comments. One of the things that you hear commonly is individuals in the dating world will say, I've never had an STD. Totally false. Everyone who has engaged in sexual intercourse, probably 98% has gotten HPV at some point in time. So as the comedian Ali Wong says, if you don't have HPV, you're a loser. That's part of her act, which is a funny line. And it just shows that the level of ignorance when people think they've never had an STD. In response to Dr. Mandel's question, there's 37 genital HPV subtypes, and there's many 100 plus more that affect other parts of the body. So of the 37 that affect mucous membranes, approximately half have cancerous tendencies, and the other half tend to cause warts. back in the bad old days, we used to treat individuals with warts, and we would just basically scorched earth everything in their body. We would zap. We no longer need to do that because we don't believe the warts are precancerous. Sometimes they're cosmetically objectionable, and we still take them out. But in response to Dr. Mandel's question, yeah, people think I took the new updated 9 vaccine, which is a great vaccine. It used to be a 4 vaccine, 2 against wart strains, 2 against cancer strains. Now it's a 9, which I believe is 7 against the cancer and 2 against the wart. And we have an additional, probably, 5 to 10 other ones. I believe they're working on that so that we can address all the cancer forming. We currently get, we think, 85% of the cancer-causing viruses. But we need to do better, and we need to explain to people they're not out of the woods. They still need to do cervical cancer testing. And the word hasn't got out there, oh, I had my HPV vaccine. And they don't understand that. So women still need to get serial HPV testing. We don't necessarily rely nearly as heavily on the pap smear, but you have to do cervical testing, and we have to work really hard. I've got, at least in my little tiny practice, 7 or 8 individuals with oral HPV cancer. We have to do better. We don't even have a good pap smear for oral. We have a vague, reasonable pap smear for people that have higher risk of anal HPV. But I believe that, research will figure out the last couple of strains. Fortunately, HPV doesn't seem to mutate that quickly. But I think this is where we need science, and we need vaccines for, a lot of these other infections as well. But here's the saddest thing. Yeah, we need a better vaccine, but how many Americans at risk have taken the HPV vaccine? Probably only 50%. We're pushing the COVID vaccine multiple times on advertisements. I cry when I hear that. We need the HPV vaccine. That's such a travesty when we advertise for a vaccine far, far less valuable than one that's going unnoticed and unused. It's really a tragedy that's causing unknown excessive deaths in this country right now.
Clearly, you're very passionate about this topic. So if you were going to give advice to the mayor and the city council, what 3 or 4 things, we'll limit to that as opposed to all of your recommendations, what 3 or 4 things would you think are the most important things for the city of Los Angeles to do to lower the spread of STDs in the city?
I would go back to the 3 things that we discussed. Number 1, how do STDs present? If you don't know, you need more education. Number 2, what STDs do you need checked so that you got a thorough check? Nobody knows. Your doctors don't necessarily know. Number 3, what's the time frame when you should go? The day after you have that high risk exposure? 2 weeks or 4 weeks? If people just knew those simple things, then I believe A, they would get far better care, and B, they'd go back and look at some of the more nuanced looks at those questions.
Dr. Lemos.
I wasn't raising my hand.
Oh, I'm sorry. Do you have a question? No.
I do. Are you
Please.
finished?
I'm
Oh,
not.
Dr. Tofani, I don't know.
Go ahead.
I wasn't raising my hand. I was scratching my face, but thank you for your presentation. I'm thinking about the bills that have been proposed in Congress that have been introduced in the past 4 years that would support sex education. I understand that sex education is made at the local and state level. So my question to you is, do you think federal support for sex education would be beneficial? And I'm just kind of wondering about the data about more conservative states and how they're faring with, the incidences of STD, since more conservative states, promote only abstinence, only education, or none at all. So it's like a 2-pronged question.
Well, that's a great question. Like, how is Utah doing compared to
Yeah.
California, for instance? I don't know the answer to that, so
Mhm.
I don't know. But I do know that certain red state issues compared to blue state issues, one of the big ones is parents of conservative kids don't want to give HPV vaccination because they go, if my child thinks they're protected from one of the key STDs, they're going to probably engage in sexual intercourse at an earlier age. That's been clearly demonstrated to be a lie. That does not happen. So I think that that's the one part about education that I think we have shown there's no negative connotation there, where sex education is going to make our children engage in either intercourse or high risk intercourse at an earlier age. I think it's the opposite. I'm not that aware of the data to back that up, but I know, for instance, there was what's called the Charlie Sheen effect. When he and I went on national TV, when he came out and declared that he had HIV, there were more searches on HPV, on HIV. There was more interest. There was more education than even on the every one of the AIDS World Days, which up until that point had been the biggest educational point. So if we go to people and we do it in an interesting way, not the usual boring top-down way. I'm the Surgeon General. This is what STDs are. That doesn't get to kids. We have to figure out a different way and have different ways into the schools. And maybe it's with rock stars, rap stars, but it can't be one of these top-down boring doctors.
Yeah, I guess I'm just thinking long term in terms of like specifically HPV and how rapidly it's growing and the cases that are going to then lead to cancer, right? This could be a national crisis and, in the years to come.
I agree 100%. I think it's really got to start with education. And it shocks me how little people know. I've never found even a doctor that knows how STDs present. They don't know. And if you know it presents with no symptoms, you would take a different course. So just that one educational thing, if we can get that out, that tells you, oh, if STDs present with nothing and then stuff starts happening inside my body, in many of the instances, maybe I should do a routine screen. We're way ahead right there. Doctors, they do this. You come in to see me. Any symptoms? No. Oh, okay. Boom. See you later. I'm in a monogamous relationship. Okay, see you later. That doesn't go with me.
Dr. Calfani.
May I ask a question? Oh, I'm sorry.
I skipped. It was my bad. I skipped Dr. Calfani. I didn't see that.
Whatever,
her hand was
that's
up.
fine.
So just because of the vice presidency, she goes first.
I'll go just really quickly. Thank you, and I support all of your recommendations. And just an FYI, there was a bill that went up actually twice, SB 94 for condoms, free condoms in public schools that the governor vetoed a second time, that had funding and support. So there's actually no reason why they shouldn't be available at schools, but for whatever reason, they are not. But there is support, and I think we'll just have to continue to fight to make that happen. When you think about the crisis and the surge, they should be available without stigma, without issues, and for free. So I think we need to continue to keep that fight going. And then the other thing I just wanted to ask, also going back maybe to what President Mindell had asked, you talked about congenital syphilis. And one of the things I realized in LA County is there's been such a focus and less focus on chlamydia and gonorrhea. And when you think about populations that are disproportionately affected, that's an area where we need more education, more education, as there's been more prevention, but so much focus has been going really to congenital syphilis. And not to say that we shouldn't, but we can't also ignore everything else if we're only focusing on one area. What other recommendations or thoughts do you have to help advocate or convince others in public health, especially those that are really driving the efforts in the county and in the city, to make sure we don't overlook or forget that we still have other populations that we need to focus on and other diseases we need to make sure that we don't overlook, because we still need to make sure that those communities are still getting the support education that's needed. You know, STI prevention, things that are preventable continues to get cut. So there's always funding. You would think we would be putting more money in these areas, but these are like the first programs and the first areas that get cut. So what other recommendations and suggestions would you have for us?
I'd really like to involve people that our youngsters look up to, you know, famous rappers and things like that, and have those sorts of things potentially even addressed at concerts, and have some kind of system where we can take these things out of everybody's got their blinders on. And if we can get somebody, in other words, there are celebrities in various diseases. There's never been a celebrity that came out and said, I have herpes. It's just such a, you know, an unspoken horror. And I think that if we have to get people that the young people look up to and relate to, and sadly, you know, it's not a doctor. And so we have to find our voices out there that have an audience online and get this message out. Like, you know, some of them get active in politics, not all, but we need them to get active in this key area, because we've got 3 million, mainly young women, maybe 2 million young women, maybe 2.5, and then a third men that are walking around with chlamydia. That's unacceptable. So we have to go after all these women under 25. So how are you going to get at them? You know, the doctors aren't interested. You know, we have to get people interested in, do they want to have kids? They're going to have to, we got to figure out a way to get to them. And I just think, you know, people that have a presence on social media, maybe some of them will take on that banner.
Thank you.
Dr. Hisser,
Thank you. Thank you for your presentation and for your work. Have you actually had the opportunity to present this material or modifications of it at secondary school level?
No, I haven't, but I have had a couple of interesting things. When I was trying to promote this book, I went on probably 30 different morning shows, and every one of them, I've been pretty frank today, said you can't use any of that language. So when I would be out there to try to push my book, I couldn't say any of this stuff. I had to just say,
Yeah.
you know, well, sexually transmitted disease, but I couldn't say any word. I can't say vagina. I can't say penis. I can't talk. I can't show a picture. That's not acceptable on TV in this country, but they can, you know what's on in terms of the stations and Euphoria and whatnot, you know, and what's on social media. But I can't talk about this book on TV. No, so I never have. This needs to go out to 7th graders. One of the crazy statistics is, you know, that really 10th graders need to know. 10-year-old, 11-year-olds need to know this.
This is probably being thrown out in libraries all over the country.
Yes. Yeah, it's that the libraries throw it out.
Yeah,
Everybody
they put them in the pile of burning books.
Yeah.
But how about at the collegiate level? I mean, is there material presented there?
I've been trying to get it into schools or just cut it up, because actually I've got a thumbnail sketch of all these different kind of interesting graphs and tables, like, hey, you know, what do you get with oral sex? What do you get with, you know, what if you have a burning when you urinate? What could that mean? You know, just make it really practical stuff you cannot get on the internet. The internet is impossible to get any of this data out of. But yeah, I haven't figured out a way how to get it in schools. I'd love to.
Thank you.
Commissioner Cotto?
Yeah, hi. Thank you very much for the time
Appreciate
you've taken to present to us. A few clarifications that maybe I didn't catch. Did you say that if all STDs are fully treated, they can't be transmitted? Was that? Or certain ones?
Certain ones.
Okay.
If you fully treat some, i.e. herpes, you markedly lower the transmission risk, but you don't eliminate it completely. However, if you completely treat the bacterial ones, chlamydia, gonorrhea, mycoplasma, trichomonas, yes, then after a very brief period of time, they are completely cured and non-transferable. And some of the ones that can't be cured, HIV being the classic. You can't cure HIV, but you can, by treating it, lower the viral level to the point that it is non-transmissible by any route, whether that's oral, rectal, or vaginal intercourse. It will not be spread.
Okay, our second presenter is going to talk about accessibility to underprivileged communities. So would you say, okay, I'm going to piggyback off of Commissioner Lemos's question about is there data about more conservative states versus liberal? But what about underrepresented communities versus, disadvantaged communities versus more wealthier communities?
There is data that shows certain states have much higher incidences of these STDs, and they do tend to be deep south states. You can draw your own inferences, and it may be public health is not as good. It may be lack of education, but there is also obviously a marked increase in urban areas.
Okay, and so in these disadvantaged communities, we're talking about we want more funding for health access, but you're looking at communities that may rely on FQHCs. They have limited budgets, and I guess their priorities probably wouldn't go towards STDs.
We've given COVID vaccination in certain instances for free, and we need to do STD testing for free in certain disadvantaged communities as well.
Okay. Well, I mean, yeah, COVID, yes. You've stressed that many times. Okay. Sorry, I don't want to keep everybody waiting out.
But there is federal funding that can go directly to community health centers and to most federally qualified health centers. So there's like bonus money. So it's in addition to their per capita payment or their monthly capitation.
The FQHCs.
Yeah.
Okay.
Or also what are called lookalikes, which meet some of the criteria of the federal government.
And separate from the funding, it's also part of just the services. So FQs are expected to provide those services. So it's not something that they should ignore. It's actually part of the services they are supposed to be providing as a safety net.
And you also mentioned how doctors need to be educated to be able to, pass on the correct information. So how is that sort of being coordinated to help doctors through all levels of service?
Well, education is tough on all levels, and you do the best you can. The doctors are very busy, and this is something that is a bone of contention, because if doctors test for herpes, for instance, they are met with hysteria because of all the current myths about herpes, for instance. So doctors are massively disincentivized to do a herpes test and to talk about it, because number one, the prevalence is so tremendously high, and it's a disease where many people that test positive don't know they had it. So when you have a disease that possibly 70% of people with the disease don't know they have it, and you test and find it, you're looking at 20 minutes or half an hour of a patient screaming and being really upset and saying, I think your test is wrong. And it takes a lot of time and counseling to do it. I think that we need to do it, but that's part of the problem. And, it's been pushed to the back burner. And I'm not exactly sure why, but that's just a fact. The other thing I'd just like to add to your last question that I forgot to mention was one of the other things in those minority clinics that should be there is obviously the vaccinations. We need vaccinations for HPV desperately in that population. We need vaccinations for hepatitis B and A if it's a immigrant that didn't get it in their country of origin. And even things like meningococcal vaccines may lower the risk of gonococcal infections by 30%. So there are some standard vaccinations. And again, we push other vaccines. I think that it's time to start pushing the HPV vaccine big time.
Okay, and one other point of clarification. You mentioned how if you discovered a patient with an STD, that now you can test or treat their partners. Was it? Can you clarify that?
Well, it used to be, I thought that you couldn't give antibiotics or a treatment to somebody that you didn't see face to face, that was a violation. I hope, and that rule was passed, I'm not sure when, where you now give the doctor permission to blindly treat a partner. And it's been a huge boon to us treating STDs.
So, is there data supporting the benefits, or?
I'm not aware of data. It's my personal observation that whereas before it was like pulling teeth to get people to have partners go to their doctor to get treatment or to come to see me for treatment, because of cost, because of embarrassment, because of many reasons. Now you give the person who's identified as having the sexually transmitted disease and you give them multiple other treatment packets and tell them, hey, make sure your partner's not allergic to this drug. And that people are very compliant with compared to the old way, in my observations.
Yeah, well, from 50 years ago when I was going to high school, I don't know if it's because there's more info out there in social media. It just seems that, there's a lot more casual sex, right? So it's harder to have patients, or come in as partners because you just don't.
Well, unfortunately, in some of the dating apps, people hook up with individuals and never know their address. So sometimes even well-intentioned people that I've had that are in these dating apps, they can't find the partner because they don't have necessarily, the phone numbers go cold and they don't know addresses. We see that, as well.
One last comment, sorry to take up so much, but how did you get Charlie Sheen to open up to discuss HIV?
Well, it's all his decision. He lived with this very painful diagnosis for 6 or 7 years, and at a certain point, he decided that he was going to come out. And I was hopeful that in that one move, he would save more people in that one declaration than I did my entire life as a physician. And I think that may have happened with the level of awareness that he raised. So my hat goes off to him to take the potential backlash and to come out as he did.
Okay, yeah, I think, that's the way to get more younger people aware is these celebrities with these different STDs would somehow have the courage to come and speak about it, that it'd be a heck of a lot more educational than trying to get these books out or telling doctors to, searches will go on, and I think the kids will really be into that. Well, thank you so much.
Appreciate it.
For your time.
California law does not allow a physician to write a prescription for a patient that's not their own patient. We're required to maintain a chart and do a whole evaluation of the patient prior to writing a prescription. That changed, the law changed with one exception, which is the situation.
No.
But that change was probably like 5-6 years ago. Good. Any other commissioners have questions? If not, thank you for your passionate talk and educating us and the people of Los Angeles who are out there listening to the talk more than you can imagine. I truly appreciate you coming down to the City Hall, and we're honored that you would take time out of your busy schedule to do so. Thank you very much.
Thank you.
For next agenda item, we're honored to have Bernice Nunez Constant, who's the Senior Vice President of Government Relations and External Affairs for Ultimed, with her work on legislation and advocacy work at the federal, state, and local levels, specifically for underrepresented communities lack access and quality affordable health care in the county of Los Angeles. And I think Ms. Constant, Ultimed is the largest FQHC in America.
In America, yes.
Which is pretty impressive. Is one of the best managed, if not the best managed, federally qualified health center, and has an amazing reach in our state and in our county. Thank you for being here.
Absolutely. Thank you, everybody, and good evening. Yeah, we do hold that title. We're very proud of it. But with that comes a lot of responsibility that we really do push for at the federal, state, and local level. And so today you'll hear me talk about who we are and our scope so that you all can understand really what's at stake, but also what makes us really special, which is who we serve, how we serve them, and then we'll go through some of the recommendations that we want to put before you to consider in terms of how we can work together, how you can better partner with, how you can more strongly partner with FQHCs, and then I'm eager to hear what your priorities are in this space as well to see how we can be supported. Next slide, please. So a little bit about Ultimed. We started as the East LA Barrio Free Clinic in 1969. We came out of the Chicano rights movement. A lot of the FQHCs and community health centers have this really awesome social justice root. And we were actually established by the Adelitas, which were the women in the brown berets back in the 60s. And so this, our organization, mission has been consistent in eliminating disparities. We focus on serving Latinos and multi-ethnic and underserved communities of Southern California. And so as you can see in our core values, it's centered on patients, our employees being our most valuable asset. Encouraging innovation and high quality health outcomes is something that we really strongly focus on to promote wellness and advocate for our communities, and really our commitment to teamwork, because we can't do it on our own. And we do really build whatever we build. We're always thinking about how this can be scaled up, be shared with other FQHCs or community health centers, and or other providers and institutions that we can be an example for. Next slide, please. This is our service area. We are in Los Angeles and Orange County. This is an interesting map because you see all of our locations, but we also like to overlay what we call the Social Vulnerability Index, which are indicators like the hard to count census tracts, areas that are civic deserts that have low voter turnouts. And then we added the high COVID-19 mortality rates, because in our area, we're actually the largest provider in Southeast Los Angeles as well, the second epicenter to the COVID pandemic after New York. And so we were frontline. We were actually the ones that opened the first testing sites. We were looking around our communities and we're like, there's nothing here, but we're seeing testing sites open up on the west side and in other more affluent areas. And so we opened up, and we were actually one of the leaders, not only here in the city of LA, but really in Southern California, making sure that these services were available. But what I want you all to know is that this is the worst perfect storm, right? Your FQHCs at the federal level, we exist literally to serve the highest need communities. It's by design. That is the only way we can get that designation. And so these are the patients that are coming through our doors every single day. And also, we have been the safe haven and legacy provider for the uninsured, which for FQHCs and medical providers has largely meant undocumented individuals and low-income individuals. And so this is our legacy in good years and bad years, deficit years, surplus years, Republican administrations, Democratic administrations, when there are raids in our communities, when there are not, we have been there. And so that's a critical, that's something that makes us really special as FQHCs. Next slide, please. Here in the city of LA, we have 12 service delivery sites. We also are in some of the housing areas like the Ramona Gardens, William Mead. We have some satellite clinics in those housing sites, which again narrows us in as really a safety net provider here in the county. Next slide. Here in the city, my apologies. Here's who we serve. So to the point of Dr. Mandel, we serve 500,000 patients in LA and Orange County. We have 84% of those are Medi-Cal. There was a point years ago where we didn't have Medi-Cal expansion for all, and that 84% Medi-Cal was more like 30% Medi-Cal, and the rest was really uninsured populations. And so, because of Medi-Cal for all, we have our highest coverage rate in Medi-Cal to date. 74% of our patients identify as Hispanic or Latino. 40% like to be served and receive their healthcare services in a language other than English, which is interesting. Very diverse population. 62% prefer Spanish as the language how they're receiving their healthcare. Our social vulnerability index there at the 93rd, almost 94th percentile out of 100. Right, we have some of the highest need communities that we're serving in the areas that we are in. In some of our areas in the city of Los Angeles, we are providing 72% of our patient visits, or what we call encounters, in Spanish. 61% of our visits are in person, and 39% are telehealth. One of the silver linings, if there are any out of the pandemic, was that FQHCs and community clinics can now provide healthcare via telehealth. We didn't have this, and we are still fighting to preserve it over the long run at the federal level, but we're well positioned here in the state of California and locally. And then that housing stability score, 87th percentile, our folks are highly likely to become housing insecure and or homeless. One additional data point there is that in the last homelessness count, the Latino rate went way up. And so that is also an indication that supports that indicator there. Here in the city of LA, in the past 12 months, we've cared for 81,000 unique patients and provided over 500,000 healthcare appointments. So it gives you an idea of who we are, what we do, and really the scope of our services. Next slide. Just to your points earlier, we are here to provide primary care. So we are providing primary care. We have over 60 service delivery sites in LA and Orange County where we provide a myriad of services, as you can see. We also are dental providers. So we provide dental care, 14 sites and over 100 schools in LA and Orange County. We really push innovation. So we have something that is called the Clinician Home Visit Program that came out of the COVID-19 pandemic when our seniors could not come in to the centers to receive their care, and so we were going to them. And so we actually have 6 clinical teams that go into the patient's home, serving 650 chronically ill patients at home. We have our own pharmacies. We have 12 sites. This is critically important because we are able to provide very highly discounted programs through the state's 340B program, and so folks really pay little to nothing for their health care, for their medications. We also are very proud of our behavioral health program. We have 18 sites. Y'all will hear me make some recommendations in this particular space because we need a lot of help in this space. We do provide HIV services. We have dedicated sites. And just to kind of close the loop, I was eagerly wanting to be called on here on the bench about the services around immunizations, how we get, even for HIV and how we get funded. There are absolutely federal funds available. There are grants that we pursue. There's also state funds available. And then we have the philanthropic community where we do very specific projects based on funding that is available. And a lot of us do a lot in this grant space, and so we get a lot of our support that way. We have mobile services, on-site specialty care. That one is particularly important for Medi-Cal eligible populations because specialists don't like to take Medi-Cal. It's, we have the 49th lowest Medi-Cal rate in the country here in California, which is, we are amazing, right? 5th largest economy, I think, at last count, 49th lowest Medi-Cal reimbursement rate in California. And so our patients really struggle. We really struggle to contract with specialists that actually will accept Medi-Cal and see our patients coming in that are really dealing with these chronic conditions that really require this specialty care. So what we're doing is bringing that specialty care on site and actually hiring specialists at Ultimate to be able to provide these services directly to our patients. And of course, we do a ton in youth services. Next slide. Wanted to highlight, we are also the largest program for all-inclusive care of the elderly in California, the second largest in the United States. This program, here in the city of LA, we have 3 sites. We have our Grand Plaza site, we have a site in South Los Angeles, and we have one in Westlake that is more of a limited site. PACE is a program that really focuses on serving really nursing home eligible seniors that are really sick, chronically ill, that are dealing with 8 to 10 chronic conditions on average, but really works to help them avoid the nursing home. For Latinos, for African American communities, for communities of color, diverse communities, we like to keep our elders at home. And so for us, this program allows us to do that, but get the support that we need and ensure that the patient is not lacking for the care that they need. And so these patients come into our center and get everything that they need. It is a full risk model, 24/7. Anything that they require, we are fully responsible for. And it is really an amazing, amazing program. This is, if you all haven't heard of PACE, it is the gold standard for healthcare. It actually has a payment rate that matches the level of service that needs to be provided. And so everyone aspires to this, but obviously it's a financing dilemma. And then we have the alternative care setting sites in Los Angeles as well. And so we have, this is a PACE model, but it's more limited. Not the full continuum of services are provided here at the VCS site. And so, but they are located very closely to a full PACE site. And therefore, we can kind of start building that pipeline into the program because there's a lot of education that needs to be done around this program. Next slide. Okay, so now I want to talk to you all about addressing health disparities and how we are advocating for health equity, and which is where we are really looking for your guidance, leadership, and partnership. Next slide. So where are we? Let me just do a quick level set. Here at the state level, we have the historic Health for All expansion that we worked on the advocate side over a decade to get done. So now everyone here in the state of California has access to Medi-Cal. People call it universal healthcare. It is not that. It is universal access to Medi-Cal for those that qualify for the program. And so it's regardless of immigration status. And we also have DACA that is now covered here in the state of California in terms of eligibility. And so DACA individuals can also now purchase their coverage through the health insurance exchanges. And so in order to make, well, let me take a step back. And so we also have a movement towards value-based care here in the state of California. I'll talk a little bit more about that, but this is an innovative practice that can really help us create flexibilities and innovation within the model of care. FQHCs are really tied to this prospective payment that is really about the provider visit. And so that value-based care will give us a little bit of flexibility to be able to be more innovative in the model of care. And we believe that this is a health equity solution. So I'll talk more about that. But in order for that to work, data access and integration is really key. And health workforce crisis. You all know, you've heard about it. It is particularly dire for Latino communities. So I'll delve in a little bit into that. At the local level, it's really about ensuring now and delivering on the promise of health for all, right? We want to make sure that now these folks have coverage, that they're eligible for coverage and that they receive it, but coverage does not equal access, right? And we know that and we understand that. And so that's what we're working to make sure that we actually create real access. Cultural and linguistic competency, there has to be a connection made there. And then a focus on the workforce pipeline and training for doctors and nurses, critically important. And then some of the immediate opportunities that we see around the corner is really Prop 1, housing support and expansion of behavioral health services for Angelenos. Prop 35, which was a statewide proposition that is on the ballot in November, that will increase and provide stable funding for Medi-Cal here in the state of California. And then Measure A, which is approximately about $1 billion of revenue annually to help combat homelessness. Next slide. Okay, so let's talk about the expansion of Medi-Cal. 700,000 newly eligible patients and beneficiaries for Medi-Cal. That is the Health for All opportunity. FQHCs, we've been their home, we've been caring for them. And so ensuring that FQHCs are in the conversation, right? Even having you all ask, hey, have you all consulted the FQHCs on this, right? Where are they on this? Is very, very important because it's not just about the funding, it is about creating that opportunity. And so value-based care. What is value-based care? Value-based care is a healthcare delivery model that really restructures our health systems to focus on health outcomes for the patients and the quality of services, and ties that to reimbursement, which is the biggest carrot that we're all looking for, right? And so it organizes the care around the patient's medical conditions and integrates the data, which we can't do this work without the data, right? Doctors are in the exam room and they're needing to have that data available in the moment to make the best decision and provide the right care at the right time. We believe value-based care will get us there. And so together, this ensures that our patients are getting the care that they need and that the integration are there, but that it is a results-driven approach. And so when someone goes into the value-based care space, an entity, they have to take on risk, right? So an entity like Ultimate would then take on that risk, and then we are responsible for managing the care, i.e. managing that dollar to get the highest health outcomes, and really it's baked in, and health equity is baked into that. And so Ultimate has been on this path, again, to the point earlier around COVID where we were the first ones and we had to push the envelope and open testing sites and do all those things. We're leading the way, right? To our knowledge, we're the only FQHC in this space right now that has really made a very significant investment in value-based care in our own journey. So we've been doing stuff around infrastructure and data interoperability, looking at our primary care and business model to really support this innovation. Our goal is to be able to secure additional funding to be the pilot and demonstration of what an FQHC can be in this space. This is new. It's usually managed care plans that exist in this space. You're not seeing this approach anchored at the FQHC, and so we hope to be the innovators in that space. But we really do believe that this is a health equity solution, that it'll get us there. Next slide. Okay. In addition, in the Medi-Cal space, we don't have payment parity, which means that the payment that we receive today doesn't cover the full cost of care that we're providing to our patients. And so we want to make sure that as we get our annual targeted rate increases, that it's appropriate and that it really is accounting for the cost of care. We also want to make sure that primary care and community health worker investments are made so that we can utilize them to help us enroll our patients, keep them engaged in their own health care. They're just such a critical piece of our equation. And then the delivery system integration. So we need to integrate it all, really, to make sure that this that social needs can be prominently part of that integration as well. But we also have to think about housing and transportation and healthy foods, right? We're hearing like food is medicine, food prescriptions, things like that, and really addressing environmental issues as well. This is where it gets super where everybody kind of probably want to do a collective sigh, right? Because it feels so overwhelming. But these are the conversations that we have to be having if we really want to make inroads to population health for the highest need. Data and IT system interoperability is key to this. This is, I think, for the data wonky people like me, it's kind of the sexy thing. We like to talk about the data, but folks really don't want to engage in this space. They really want to focus on services. We can't get to a space where there is high quality services that are validated. We're making sure that we're using the money in the right way, and that we're getting the high quality outcomes if we don't have the data, the system to support that ultimate data that we need to get from the system. And so this one's critically important. And then quality measurement. Today, as a FQHC, we have to provide quality measures and outcomes to health plans 10 different ways. There is not one way that we do this. There is a statewide push to try to push for some of this. We've been trying to work with the California Department of Healthcare Services to do this. Again, leading the way in this space, but we've not made the inroads we need to make. But I just want to bring it to your attention. This is a state level issue, but it is something that is really creating a stoppage in terms of quality measure reporting. and really creating an administrative burden, I should say, for providers. And then incentivizing primary care. I mean, you heard from our previous speaker that everything that is required for primary care, sometimes it's seen as an afterthought. If you look at the investments around healthcare, primary care is this tiny piece of that pie. And so we're always fighting to make sure that we're getting more in that space. Next slide. Also making sure that Medi-Cal coverage is on par with private insurance. We talked a little bit about that. I'm sure a lot of you have heard here in California, we have this two-tier system, right, for healthcare. You have all of those of us that have the privilege of having access to employer-sponsored commercial insurance, and then you have everybody else who's on these government-sponsored programs. Absent of Medicare, that is really an amazingly funded program. Medi-Cal, again, here in California, 49th lowest Medi-Cal reimbursement rate in the country, and so it just makes it a very, very challenging environment to exist in. We've been in this space for a long time, and we chose to double down in this space for the legacy of Ultimate, right? We just celebrated our 55-year anniversary. And there are a lot of entrants that are coming into this market as well, because I think we're kind of at critical mass as it relates here in the state of California. There's not an additional pots of new enrollees, right? And so folks are really starting to come into this space. So this is something that you all should just have your eyes on, that as folks enter this space, that they really are focused on making sure that there's high quality care to these populations. And then, of course, enrollment and coverage is going to continue to be key. Timely access to care. We've coined this term of addressing language deserts. And so we know about healthcare deserts. We're also talking about civic deserts, but there is such a thing as language deserts. If you look at our healthcare workforce today, there's a lot that we have to do to create a workforce that speaks the languages of the patients that we care for every single day. In particular, the Latino's dilemma is a big one, and so I will talk about that hopefully next year. Next slide. Healthcare workforce. Let me go to that, and I think I'm going to. Oh no, there's my doctor point. Okay, so Los Angeles County really faces a critical shortage of nurses. You all have heard this, but I think we should repeat that. Today, medical providers, hospitals and clinics have a vacancy rate of nurse positions at 10 to 15%. We post them. It's really hard to recruit. And then you look at a clinic competing with a hospital in terms of salaries. There's no way we can get to that in terms of payment and salary for our nurses, and given our reimbursement structure. And so that's a challenge for retention. Also, a recent survey found that 60% of healthcare workers in Los Angeles are burning out. They've burnt out, right? COVID happened. We were, I think, already a little burnt out. I will only speak for myself, but a little burnt out before the pandemic. The pandemic happened. And then I think what happened after the pandemic is that we just continued, right? Now our workload was here, and we just added everything else that we should have been doing over the pandemic, right? And so it's really at an all-time high. And then, of course, despite Latinos being nearly 48% of the population in LA County, we only represent about 6% of physicians. Only 6% of physicians identify as Latino. And so there is a severe Latino physician shortage to the point where it is now impacting health outcomes, and that is research that we are starting to do. So more to come on that. Next slide. One of our solutions at Ultimate to address workforce has been to establish the Ultimate Institute of Health Equity. And again, it's something that makes us really unique. We do have a research arm. This is where our grants teams lives as well. And this is where we do a lot of our residency training programs. So Ultimate is a teaching health center. We have our own residency programs, family medicine residency, nurse practitioner, sports medicine. We work with Children's Hospital Los Angeles, USC, White Memorial, and all of this is we're training the next generation of providers anchored at the community health center or federally qualified health center, which is really the game changer here. We now know that our retention rate in these programs is through the roof. We have cohorts coming in and we are hanging on. We are retaining and hiring over 90+% of these folks. They're staying with us. There are other programs for bigger players in the market that, maybe retain 2 of 30 residents coming in. And so to just give you a little comparison point. And so we're training the next generation of providers. We are also training our own workforce, right? So we've got to train the new ones, and we've got to make sure that we're training our workforce, and that's a tough one. But we are doing a lot on Medicaid-assisted treatment, opioid use disorder training, stuff around PrEP and PEP, HIV training. We're doing stuff around adverse childhood experiences or ACEs screenings, and then regular course of care like phlebotomy training. These are all things we're having to train. We're also starting our own Ultimate School of Nursing Collaborative. It is because we are having that dilemma of recruiting our nurses. And so what we're doing now is we said, hey, we have medical assistants and certified nurses assistants that are already committed to this work. Why don't we pay for them to become LVNs? And why don't we pay for them to become RNs and RN BSNs? And why don't we pay for them if they want to become a nurse practitioner as well? So today at Ultimate, that whole trajectory is paid for, partially because we need this, but partially because we're committed to social justice. And so imagine what that means for an individual that is a nurse assistant, a CNA that is now receiving an RN salary. Imagine, you can see what that means for the family unit, right? And so we're really proud of that part. It's a lot of community power building, and it really is an investment in our communities. And then finally, we have our training programs we do around dentistry. We have field study programs. We do community-based participatory research, stuff around social work, and for study programs on masters of social work. And so we are deep in this work and really investing in the healthcare pipeline. Next slide. So here's what we need. We need more FQHCs to be seen as a training ground for these types of programs. Academic institutions have typically worked with other academic institutions, right? And so we have now built out, we really had to demonstrate that FQHCs could be this very fertile ground, that we could do it in a high quality way, and that we could retain those physicians in the communities that we need them to be in. And so FQHCs need to be thought of in this way. So we're making inroads with the Charles Rood universities of the world. We're with UCLA, but we have a lot of work to do, and for FQHCs as a whole as well. In addition, prioritizing funding and support partnerships to train our nursing workforce. You all have heard this over and over, but it is very, very important. Right now, we are pursuing funding for our Ultimate School Nursing Collaborative at the federal level. And it really is, in the first year, if we get this right, we will be able to fund 250 licensed vocational nurses, certified nursing assistants, registered nurses, within the first 3 years of the program. And so we're working with the University of Laverne and the Annenberg School of Nursing in order to do that. Monumental contribution to the field, to our communities, and to the space, but it is very expensive. So we're working hard to make sure that we get those dollars and hopefully some federal funding. Primary care residency programs, a lot of folks are going into these specialty care. Making sure that these solutions are anchored at the community health center is going to be really, really important. And then protecting the different programs that we have at the state level, like the Songground Primary Care Residency Program. This was on the chopping block this year, given our state deficit. Thankfully, we were able to save it. But these are the types of advocacy opportunities that exist at the state level if you all want to get involved at that level. We also, again, the idea of language deserts, newer concept. We're trying to work with an academic institution to really kind of carve out a space for this, but I think you all can see how much this makes sense. If a patient comes into a doctor's office and cannot communicate with their doctor, and their doctor cannot understand what they're saying, or there's a cultural barrier, then they don't have true access to care. And so this one's critically important. Here in the state of California, we do have Mexico pilot program. This is a bill, AB 1045, that passed 20 years ago to allow 30 physicians to come from Mexico and provide care. This is important because we know it takes about 20 years, right? 20 years or so to create a doctor. Right, but we have to fill the gap now. We've expanded Medi-Cal. That has happened. It's happening today. 700,000 new enrollees into Medi-Cal, or eligible enrollees into Medi-Cal. And so we have to fill the gap somehow. And so this program is working with an accredited university in Mexico. We are already in year 2 of this pilot. And this year we were successful in the state of California to get this expanded. And so this will continue to grow. So keep your eye on this. But this is a good way that we are actually bridging that cultural competency gap today. And Ultimate is the only participant that is participating in this pilot today in an urban area, and it's serving here in the city of Los Angeles. Next slide. Senior services. The senior population is growing here in Los Angeles County. 2 million senior residents. 2 million residents are age 60 years plus. This is expected to only continue to grow. 2.5 million by 2030. 3 million by 2060. And so we know we have to do a lot in this space. You look at your seniors and you just overlay any other issue, and it gets that much more complex. And so we are doing a ton in this space. We're also starting to narrow in around senior homelessness, right? And how Ultimate and federally qualified health centers can position themselves and do more work in this space. 45% of homeless individuals in California are age 50 plus. And here in Los Angeles County, that's about 17,837 adults that are 55 plus that have interacted with the homeless response system. So all the red flags are happening in this space. You also just can overlay, race, ethnicity, male, female, all of that, and it just gets worse and worse as we dig into this. So we're starting to really dig in this space as well. Next slide. So we believe that PACE is a good solution in this space. PACE, again, is the gold standard. And so here at Ultimate, it really has been a game changer for how we serve our seniors. This is the highest caliber care, and folks who have Medicare and Medi-Cal have access to a program like this. Again, we're the largest provider in the state of California, and here in the city of LA, we have 2 PACE sites and 1 alternative care setting where we serve over 1,000 seniors. These are seniors who would be in the nursing home if they were not in this program. And so if you talk about where are some opportunities for cost savings for the city of Los Angeles, this is one of those programs. Because we're going to pay it at the nursing home and through chronic conditions, but we can also just kind of pay it in this program. This is a federal state funded program, and there is an opportunity to really elevate this and create this as an opportunity and an option that wouldn't cost the city any more money. It's just about helping to promote the program as an option for Angelenos. And then at Ultimate, we're starting a new program called Viva Gold or Viva Oro. This is a specialized care program for seniors that are 62 plus. So in order to qualify for PACE, you have to have that high complexity in terms of being nursing home eligible. We also know there are folks who are out there that are that are seniors, but that are healthy and they're home, and we want to keep them that way. In the Medi-Cal space, there's really not kind of a Medicare Advantage type of program, service available, a program. Medicare Advantage is seen as a really well-funded program at the federal level that provides not only the healthcare services, but a lot of other services like memberships to the gym, additional incentives for food. I mean, it is a very kind of coveted program in Medicare. We don't have that in Medi-Cal. So we were trying to create that for our Medi-Cal eligible seniors that are coming through our program. So we're in year 2 of this program. We just opened some new sites, and so we're excited to report back when you invite us back. Next slide. And so here at the City of LA, as I mentioned, advocate for PACE to be a program of choice for Medi-Cal beneficiaries. That's all. No additional funding is needed in this space, just making sure that we're working together to promote the program. And then in terms of addressing housing challenges for seniors living in Los Angeles, you all have an opportunity to support the development of affordable housing supports for seniors through various existing state programs. So you all have heard of CalAIM and also the Prop 1 funding that is coming. You all are going to probably be needing partners. Please consider FQHCs as partners in the space because we will really bring that additional element that I think is often lacking in this type of work. Zoning reform for innovative solutions, explore provision of on-site medical and social services at these senior housing developments. Sometimes there are zoning issues that really get in the way to be able to provide these services, and so that is something that you all can hopefully dig into. And then, of course, always partnering with CBOs so that it's community informed, as we always say. Next slide. Here's the opportunity on Proposition 1. So this is funding that came down at the state level, not without without a good fair amount of controversy, but it did pass in the primary election here in the state of California. And so Ultimate or clinics like Ultimate FQHCs offer behavioral health services today. And so today Ultimate has 16 sites in LA County that are offering prevention and early intervention services in behavioral health. We also offer them in person and through telehealth. We're offering these services at schools as well. So today Ultimate is in 8 schools in Los Angeles providing counseling and on-site services, and then they are referred to Ultimate locations if they require additional support. And so we are also working with the city of Vernon. Interesting opportunity. They had a big SAMHSA grant, and they were looking for a partner to come into that area to provide behavioral health needs at the city level. And so we're also working with them on a pilot of sorts to be able to build out a program and really utilize that as a model to scale up in other places. And so we will be well positioned for a partnership if we had the opportunity here in the city of LA. Next slide. So immediate opportunities. I think I'm in home stretch here. Prop 1, right? We got to make sure that the city of LA is applying and continues to apply for these funds. There will be different phases of this funding that will be coming down. Round 1 of this funding has, I believe, is completed already, but again, it's a rolling. There will be additional opportunity for funding. Round 1 awardees, a partnership with FQHCs like Ultimate to successfully expand behavioral health services to Angelinos experiencing housing insecurity will be, I think, the game changer that we both need, right? You saw our scope of services, FQHCs. There are other large FQHCs as well. We always like to elevate our FQHC partners as well. And we are already well positioned. We're already doing this work and serving the highest need communities. And so we would be, I think, a very well-aligned partner for the city of LA. Measure A, there's going to be approximately $1 billion in sales tax revenue annually to combat homelessness. Opportunities to partner with the city and county to find ways to expand services to homeless individuals. We already do work around substance use treatment. Of course, we provide primary care through our clinics and our very expansive provider network. And so again, I think FQHCs would be very well positioned to partner with the city on Measure A, and then Proposition 35. Proposition 35 is a prop that is on the November ballot that is directing a state managed care organization tax to be approved to exist in perpetuity here in the state of California that earmarks funds directly for Medi-Cal. And so we are part of a coalition, including the California Medical Association, Planned Parenthood, the hospitals. We have the ambulance providers. We have the local health plans, the FQHCs. I mean, a historic coalition that was able to come together because Medi-Cal reimbursement is so dire in the state. And so until we make the investments and we can count on that investment and that funding, we will never be able to address population health. A provider is not going to be able to build out a program if they don't know that in 5 years that funding is going to be available. And then if we're really taking on health equity, we have to take that on over the long term. And so something like Prop 35 can help providers like us that are really focused on serving Medi-Cal to have predictable funding so that we can be supported over the long run. And so we're hoping, as a nonprofit, we're able to take positions on propositions. And so this is one that we're really pushing in terms of Medi-Cal. And I think that is my show. Thank you very much. Appreciate the time.
Wow, what a show. First, take a deep breath because you gave us a lot of information and you probably haven't breathed in the last 45 minutes. So you mentioned, and we're aware, and I think we've discussed this with other presenters over the last several years, that Medi-Cal is the 49th lowest payer of the 51 Medicaid systems in America. And yet, when Sacramento got COVID funds of over $95 billion, they didn't increase Medi-Cal reimbursement rates at all. They used the money for other things, and now there's no money left. Why is it that we have known health equity issues, population issues in LA County? More than 50% of the population has Medi-Cal, your population much higher. How come Sacramento doesn't increase the Medi-Cal rates?
So a bit of fact and a little bit of opinion, if that's okay. The fact of the matter is that we have a two-tier system here in the state of California and really nationally. We accept that commercial payers can get a certain level of care. Commercial beneficiaries can get a certain level of care. And we accept that Medi-Cal is funded the way that it is and in such a limited form. There's an acceptance there that is happening here in the state of California and really nationally. There's also the overlay that the undocumented are the ones that, are really causing this cost of high cost of care. So now we have the opportunity to cover them, right? Absolutely, we will see that this is the better option, right? It's going to save us money. And so I think to your question, we have this two-tier system that hasn't been addressed to date. And so Sacramento needs to get serious about that. And so the opinion part is that we have the undocumented at the table, right? And we have FQHCs at the table. And these folks have these groups have historically not had a voice in the advocacy and the political process. And so when you're not at the table, right, you're on the menu, as they say. And because of that, because the elected officials that are in place perhaps have not gotten the pressure from these folks that really are not safe in these spaces or don't feel welcomed in these spaces, I think that the advocacy necessary to create that type of change has actually not occurred, in my opinion.
So you mentioned the Medi-Cal expansion, which is California-based. It's not specific to LA County or LA City, and increased 700,000 individuals' lives into the system. But that was for people who were undocumented and were indigent. What about people who are over 65 or chronically disabled but also undocumented? They don't get into the Medicare system because the Medicare system is federal, 100%, as opposed to matched with the Medi-Cal money. What happens to those patients in this population?
They qualify for Medi-Cal.
So they get the Medi-Cal, but they don't get the Medi-Cal.
Absolutely. So what we're seeing now in a lot of our senior programs is Medi-Cal only patients coming in. And so that's causing some financing pressure because these senior serving healthcare programs have largely relied on Medicare and Medi-Cal. And so now we're getting a lot of Medi-Cal onlys. And so that's another flag.
Medicare is more highly reimbursed than Medi-Cal,
Absolutely.
but you're providing the same services to an individual, but being reimbursed by Medi-Cal.
Yes.
So unfortunately, you're not getting enough revenue to pay for your fixed costs, basically, or even your variable costs. With this, you have a increased number of people who are being paid for your services, but you still have a percentage of population that's totally uninsured for one reason or another. Approximately what percentage is that?
So I think it was about 85% of our patients or so, if I remember let me just take a quick look. So the remainder of that would be, 1 second. So we have 84% of our folks are on Medi-Cal, right? So that leaves us with about 16% of folks who are still uninsured.
But some of those patients have Medicare. Some of those patients have Blue Cross or Blue Shield, theoretically.
Yeah, for FQHCs, that's always been a very small percentage, less than 5% of our pot. So I would say that still leaves about 10 to 12%. And for an organization that serves 500,000, it's still very substantial, right?
So do you get that all from philanthropy, or do you get that from just being very efficient and cost shifting onto that population?
Yeah, no, we use something called a sliding fee scale. So it becomes based on their income. And so they really pay little to like nothing for their healthcare services and when they come into Ultimate. And also our board has really taken a really strong position in really limiting that payment that comes out of pocket for our patients. And so we do raise a lot of money. We do have a foundation at Ultimate where we raise dollars to help support our patients who cannot afford their care, which is typically like $20 or less out of pocket.
Right. So I did an analysis. It's a very stale analysis, so it's not contemporary in the sense of real costs. But the last time I did the analysis in the entire county of Los Angeles, in this patient population, the FQHCs, it was costing them about 4% administratively to chase those funds, and they were getting about 1.8%, which the last time I did my math was 2.2% loss. So it makes no sense at all. You'd probably be better off just giving them free, even though that's federally not allowed.
Right, exactly. But your logic is right.
Right, but after 3 months or a good faith effort, you can write it off, which is what you end up doing. So we're wasting society's money. We'd be better off just giving away for free. I tried to get that changed in the ACA, and actually got lobbied against, but that's another story for alcohol in our hands.
Have to amend it.
In regards to the nursing and mental health provider service shortages, it's clear 10-15% shortages all throughout the county. It costs more money to live in LA County than it does elsewhere in the country. Nurses can get paid more here, but it costs more to live, and hence they'll go elsewhere. Just a classic supply and demand. So how do you address that? How do you are you paying as much as non-FQHC providers? Is that what you have to do, or is it mostly that the nurses are being paid less and they're doing it as a calling to the population?
On average, we are not able to pay them more than like a hospital. Are we doing what we can to pay them more at Ultimate? Absolutely. And that goes for our entire workforce. At Ultimate, we have a $25 living wage by 2025. There was a bill that passed at the state level in order to have all community clinics pay that, which comes with its own challenges because, again, as the largest, we have to uplift the smaller organizations that are in the space. And so a lot of them are not going to be able to do that. We have a diversified portfolio of businesses. You saw we have our clinics, we have PACE, we have our foundation. It is different. There are small organizations and community clinics in the city of LA that they have 1 or 2 sites, and they're only federally qualified health centers. And in order to pay that is going to be challenging for them. So, but to your question, it's a challenge. It's one of the things where we when we do these pipeline programs, we ask them to stay with us and commit to stay with us for 3 years after we pay for this. But after that, we are finding that we are struggling with keeping them because it is such profitable market for them out there. And so where we lean in, it's mission. That's why it's so important. That's where we win by leaps and bounds. We have a lot of boomerang nurses and employees that go to, other areas, and then they come back to Ultimate, or they come back to work in the FQHC space because they want to serve their community. That's why someone like me is here as well. I come from these communities, and that's where I want to dedicate my career, right? And so that's where we win. So training them at the federally qualified health center is where we also win, because we get them early, and then we can retain them over the long run. And so a lot of our providers are with us for many, many years after they come through our programs because of that reason. But that's our edge. Someone like a Cedars-Sinai or Kaiser, very different systems. That mission is there, but in a very different way.
And then you mentioned, I think, the 340B pharmacy program.
Yes.
Most places that run that efficiently, it's a net positive. They generate revenue. I'm assuming you guys are pretty efficient in everything you do, so you're probably making significant amount of positive cash flow there. Do you have an idea in your whole system how much net positive you get from your 340B?
I don't have a number, but I'm happy to commit to circle back with you all. You're absolutely right that it is a net positive for most participants in the program. There's some controversy around the types of providers, like hospitals versus a clinic. But at a clinic, we do use that additional profit or savings to reinvest back into the system and provide additional services that our patients need.
Right. So our research associates can be in contact with you. We can get that information.
Wonderful.
We do make an annual report to the city council and the mayor, et cetera. And so we include data that's important so that they can have a better sense of the providers like yourself who are doing great work. Dr. Califani, do you have questions?
Less of a question, more of a comment. So thank you. I'm always excited to have someone from the clinic come. I come from FQHC world, so I'm a little biased. So I'm always excited to hear. And Ultimate is also one of our Title 10 health centers. So it was like she didn't mention that, but so I will throw that out there.
Thank you. Thank you for that.
Which also means they do a lot of work around sexual and reproductive health care and support that effort. And so wanted to just raise that as well. But I had a quick question. I do have one quick question because I think Ultimate is very different in comparison to some of the other ones because of lots of different things, the foundation and the different programs. And Ultimate has an IPA.
Yes.
So I'm curious, especially around the value-based care and the investment, is Ultimate able to do that because of the IPA, or is there something else? Because it's I'm sure the other FQHCs would like to be able to do something similar, to be able to invest that way. But you all have, kind of, a mix of funds to be able to do that. Is that part of it, or is there some other kind of funding or revenue formula to support that? And do you have recommendations for others to be able to kind of step into that?
Yeah. Thank you for bringing the Title 10 up. Absolutely, we're super proud of that work, and so super important. But yeah, what makes us different at Ultimate is that we're as close to a closed integrated system without being closed. Kaiser is a fully integrated system, right? So they hire their doctors, they have their own hospitals. At Ultimate, we have everything but the hospital. And so we have our clinics where we're providing the services, primary care. We have a senior services line of business, PACE, right? But we also have the new programs that are coming out. We have a managed care line of business. Ultimate has a restricted Knox-Keene license that gives us responsibility over everything except the hospital. And so we manage care of our patients that are coming through our clinics through that. And then we also have an IPA, which is a group of doctors that are contracted with us to provide the services that we need and be able to serve as the network of providers that we need. And so that's almost all of it that we need in order to be a fully integrated system. We're almost there. And so because we have all those lines of business, you're absolutely right in saying that our financial portfolio is diversified. I wouldn't say that we can do this because of the IPA. I would say this that we can do this because we have diversified our portfolio. And so we are not fully just counting on the clinic so we are able to take on more risk because we have a diversified portfolio. And so the value-based care equation that we put forward is to help other clinics do what we are doing and build out these pieces so that they can exist in this value-based care space and be able to compete.
I have a question that's related to financials too, because that was exactly my question in terms of the low medical rates and how you offset the cost of dealing with a chronically ill population. And we know that the cost of care is more than these medical rates are able to give FQHC. So my question is exactly that. How do you offset the costs in your organization? Because I'm sure that it's presented some type of financial challenges in the past. And so I wanted to know, how do you cover the gaps?
Sure. So the system I just described is really new. We received our restricted Knox-Keene license in 2020. Good timing, huh? Early 2020. And so we didn't know how we were going to do that, but so it's new. So we are still working our way through that. Historically, how we've been able to sustain ourselves has been through grants. Having a very robust grants team that is really seeking funds at all the levels, and then having an ultimate foundation where we literally have fundraising efforts to be able to provide additional support. And then the other final piece, which is not substantial, but it is kind of very mission oriented, is that we also have an employee giving program where our employees, called Ultimate Gives, where our employees choose to give into this pot of money, and this pot of money is used to directly support our patients. We've done things like pay somebody's rent so that they don't, lose their apartment, paid for somebody's mobile home to be fixed because they are living in that mobile home, and we've done we've supported folks to get out of their living situation because they're maybe not in a safe situation, and so all this together is how we've been able to really sustain ourselves because we had to diversify in order to be able to do that.
Awesome. I was formerly in the FQ world, so I really admire just the innovation that you really bring to the space. And so the next is a comment. So I wanted to applaud all the different partnerships with the academic institutions, the residency programs, doctors and dentists from Mexico, because these are ways to prepare the next physicians of color and to diversify the healthcare workforce, especially with the Supreme Court's decision to end affirmative action. You can see how even more challenging it is going to be now to have a diversified workforce, and consequently impacting health equity, healthcare adherence from patients who no longer have, added physicians who look like them, speak their language. So I just want to say applaud this and really see innovation as necessary to fill the gap now because of that, overturn of the affirmative action.
Yeah, thank you. I really appreciate that. Thank you.
Me? Okay. Thank you for your presentation. In the event that one of your patients has to be hospitalized, do you have agreements with various hospitals, and do your physicians continue to attend them, or do you hand them off?
Yeah, so if they are in the Ultimate Health Network, we have the responsibility, and so we have contracts with hospitals. So that we have the adequate network, so like the White Memorials of the world and the Cedars-Sinais of the world.
Use White Memorial?
White Memorial, yeah, we just had their gala last night. So absolutely, and so when they are our ultimate patients, they are part of our Ultimate Health Network, so that we're their insurance. We are then managing their care and working with the hospitals directly, so there is no handoff. We're actually coordinating their care and making sure that we can get them home with the services that they need and the right outcome.
the physicians that are in the group that you affiliate with, IPA, I think you said, do they also have privileges in a variety of hospitals?
I would imagine so, because those are private docs, and so they have their own contractual relationships. What I can speak to is our doctors at Ultimate. We hire our own physicians, but it is Ultimate who is contracted with that hospital, not the individual provider.
Thank you.
Sure.
Thank you, not only for your presentation, but for all the work that you're doing, your organization is doing to serve the population here. I think it seems a lot of the healthcare expenses go towards helping people with their symptoms. And I know has to be a tipping point of trying to be preventative to get them from getting sick. The city of Los Angeles adopted a plan for a healthy LA that would help promote health to prevent people from getting sick. Unfortunately, that plan was sitting on the shelf until the passage of SB 1000, I think, in 2020. I don't know if you're aware of this, where the state mandated local governments to bring more justice to the underserved communities. So this kick-started, once again, city planning to look into the different elements of the plan for a healthy LA. And I know, some of the other FQHCs in other counties, Alameda County, they started a program called Recipe for Health. And I think part of that is paid by Medi-Cal, where they work with local farmers, bring in, get people interested in bringing in their produce and having cooking classes and getting the people to think about what they're going to eat that are healthier so that they don't get sick in the future. Now, do you have any plans? I know you're really busy trying to keep caught up with treating the people, but to go into that preventative phase.
So we want to be there in that preventative space, right? That I think that is the name of the game for all of us in this space. If we're doing it right, we're spending most of our time in the prevention space. Unfortunately, we are not there by any stretch of the imagination, especially with the expansion of Health for All. We now are seeing folks that for the first time in their history of being here in California have a stable healthcare provider. They're coming with the most severe chronic conditions. And so our goal is to get there. We do a lot of fun stuff around cooking and prevention, and we have a STOMP program for children for diabetes prevention. We do a lot of stuff around colon cancer, colonoscopy type of promotion. It's one of our quality indicators that we're always pursuing. And so we do a lot of stuff around breast cancer awareness. And so we want to be there. The system as a whole, though, is not really set up, and is not really set up, I will say it, to really be in the prevention space. If again, it would be amazing for us to be able to get to a space, and we believe value-based care can help us do that. That we have some flexibilities in the payment models where it's not just all centered on the medical provider and that doctor visit, but that if a patient has a cold, they can come in and see an RN or a nurse practitioner, or if they have social service needs, they can see a promotora or a community health worker, and we're not just tied to that physician visit, even though that it's always there and available as needed, right? I think until we figure out the financing equation, we're not going to ever really kind of focus on what seems like a nice to have, which is prevention. So that's a lot of words to say that I hope that is the hope.
Okay, thank you. Just a couple of quick questions. Your home visits, does that include hospice care or?
So no, it's all mostly primary care based. Once it starts getting very complex, we will bring in the relevant provider to be able to provide that service.
Okay. Yeah, it's getting late, so I think maybe I could send emails.
And you can go through them or directly to her
Okay.
as well. Dr. Califani, you had another question?
Yeah, just really quickly. Your recommendations or your ask of us, I just wanted to be clear. You talked a lot about the PACE program. So one of your ask of us is to make sure that we include perhaps in our report that we share. It's about the promotion of the PACE program.
Yeah, it should be a choice for folks who are potentially eligible. We often find that it's not everywhere that, but yes, that is one of the asks.
And then you mentioned it, and I forgot to ask about it. So in terms of the kind of the tiered or the opportunities for nurses, is that also an opportunity for the promotoras that work with you all?
Absolutely.
So
If
they
would be
wanted to
interested,
become, okay,
we can train them to become CNAs, medical assistants, LVNs. Absolutely. That's actually would be the dream to be able to do that.
all right.
Yes.
Thank you so much.
Or got funding to create your own nursing school.
Yes.
Um,
Exactly. We need our nursing school.
We would think the shortage of nurses in California that the state colleges would expand the nursing programs that'll have waiting lists with high quality individuals applying that we're rejecting, and yet we spend money on other things as opposed to what we really need. Makes no sense to me. Any other individuals with a question? Any other commissioners?
Just a comment. That was my thought process too. I'm like, Altima should just become their own school of fill in the blank.
We want to do that. You know, it just is. FQHCs haven't been historically, seen in this space. And then there's the UCs and the structures. There's a lot of barriers, but we're trying to identify those partnerships, like we are doing now with the University of Lundberg, the Annenberg School of Nursing, Charles Drew, to create that bridge, because we want to make sure that we're advocating at the federal, state level to bring those dollars and those resources in, but we want to retain the folks we're training in the areas where we need them. And so that incentive for them to remain there, mission only gets you so far. So we do have a lot of work to do in that space. But to your point, that's the dream.
Wonderful. Well, you guys do great work. We really appreciate that you came here today to educate us and educate the people of City of Los Angeles. We're really honored by your presentation. It was really superb. Thank you very much.
Thank you, and have a good evening. Thank you for having us.
Thanks. Any new business for the commissioners? We have two speakers set up for November. November, because of Veterans Day, is going to be, I believe, on November 18th. Is the tentative date? Is that correct?
Let's see, so Veterans Day is November 11th,
Correct.
which is the second Monday of the month, so we need to move the meeting to the 18th unless you want to pick a different day.
Okay, yes. Who are the speakers that we have lined up?
There was one speaker that was tentatively going to be here today who bumped, and I will defer to a research associate. There was another individual, and if I didn't just have a 68th birthday, I would be able to tell you off the top of my head, but I'd have to check.
I also have additional speakers, community-based organizations who are non-medical providers who do a lot of wellness programs and through an SDOH model. So I wanted to bring them in, but I haven't emailed you, so I will do that.
Great, wonderful.
Can I ask a research associate
Please.
a question? Monica, did Kevin Brunke, the legislative deputy for City 11, confirm for next month?
He's not confirmed, but we are meeting with him November 5th to go over the presentations. So hopefully those 2 weeks in between will be enough for him to put something together. But he hasn't exactly confirmed if he will be presenting during November. But I will follow up with him to see if he can make it for November.
Okay. Are you going to meet here in person or on Zoom?
We're doing it virtually.
Okay.
You could be invited.
Can
to
I be invited to that?
Yes.
I'm from that council district, and
Yeah.
So
Please invite Commissioner Kato. Yes.
And just one thing I'd like to clarify, Mr. He is the legislative deputy, I believe, for the council member.
Right.
Councilman Park. He may not be the person that is the expert or working on, whatever preparations are in place for the Olympic and Paralympic Games in terms of the health related issues, but he would probably help make that connection in terms of somebody that's with the task force that's different from the council ad hoc committee on this. And so that would be your conversation, is trying to find out who's around, who can they get, what's going on, what are the plans, and then see if he can kind of be that person to help make that connection.
Yes, that's the point, because exactly as you said, and so there is the Olympic Committee that's not involved with the City Council, and they liaison with the ad hoc council committee, which is led by Councilwoman Tracy Park. And so he would probably be the person that could introduce us to the person that may be able to present on our request, which would mean that it could be further down the line.
And just one other thing, Commissioner Ho had asked about this, and that is there were 2 reports that came into the council that are scheduled to be considered by the Neighborhoods and Community Enrichment Committee, and it has to do with the updated agreement with the county in terms of the types of services that the county is supposed to provide to the city of Los Angeles. And I think that they're more specifically focusing on the homeless population. That agreement hasn't been updated in, decades. And there's an update to that agreement that's being discussed. The city attorney, and Heather, you may have more information on this than I do. I know Barack has been involved in these meetings. Is that the city attorney's position is that that the city should not sign the agreement as it is being proposed currently, because it's putting more of the financial burden on the city. But since then, the city administrative officer has also submitted a report on the same issue with recommendations for the council to consider. And one of those recommendations involves this commission. And it's basically proposing that there be an establishment of an office within the office of the city administrative officer to oversee the provision of services by the county to the city, and with 5 positions, a chief, somebody at the chief management level, which is kind of at the GM, AGM, executive director level, probably higher than executive director, 3 analysts, and a data person. And then this commission would then move from the city clerk's office to be under the city administrative officer's office, and to work to be the advisory commission to this new office. This is still obviously just the initial part, initial report. It's I believe it's going to be. I don't think it's been scheduled yet, but it's the council file I sent to you all. I sent you a link, and I can send that out again to you after this meeting, so that you have that and you can go through both the city attorney report and the city administrative officer's report. And so it'd be something to kind of keep in mind. And if we can always find out if there's somebody within the city administrative officer's office that would be available and willing to come and talk to this commission about what what the thought is for the for their recommendation to council going forward, or they may want to wait until it's initially considered by the council committee, I'm not sure, but in any case, I thought you might want to have that, you know, in the back of your head that that's coming and there's going to be discussion, and that might be a place for the commit, you know, somebody for this commission basically to have a position on it, maybe, or at least offer some public comment at the time or what have you. So,
Question. So they're going to use their current city staff and designate them to do this work, correct? They're not looking at new hires to fulfill.
I don't know.
Okay.
I don't know.
I would just make a recommendation to, if there's to be a substantive discussion, to agendize it for the future.
Okay.
But thank you.
Can I make a comment?
I'd actually say that we should, for the next meeting, put that on the agenda, is a fact finding of the Chief Administrative Office's proposal. Have the small portion of that report that's already gone to the City Council, but that just one section be available on our agenda, so people can learn more about it. Send it out beforehand to all the commissioners so that they can read that. I know you did the whole long report, but I think it's 85 pages, and they probably would only want to look at the few pages that really concern us. And I think we should have a meaningful discussion about it.
Okay.
Please.
So in the October council committee meeting for community engagement, they were supposed to agendize a discussion about our annual plan, and they canceled the first and third Wednesday meeting. So I'm pretty sure it's going to be coming up in November, next week, Wednesday. I had been planning to attend either of the October meetings, but since they were canceled, to represent the Health Commission, but be good if somebody could, if it is agendized, it won't, it's not.
It's not on the agenda for the first meeting in November.
Okay.
I'm going to contact the legislative deputy for the committee chair to find out if it's projected to be on their agenda for the second meeting in November. But they did not agendize it for the first meeting in November.
Okay, thank you.
I'm not sure about the reason why, but I'll ask.
I wouldn't be able to attend the next one, so I was hoping someone else could be there if it was agendized, but if it's not, we don't have to worry.
I think I was aware it was not on the agenda, but we should hopefully get more than a week's notice when it does get agendized, and so that we can move around a schedule so one of us could be there. Any other?
Just one last thing. The research associates are also exploring a follow-up from Dr. Gregory and the other physician that was with her for a presentation around Black maternal health. So as a follow-up to that discussion,
Great, wonderful,
someone from the panel.
excellent, perfect.
Can I move to adjourn the meeting?
I have one more
Oh.
comment, sorry. Just wanted to let you guys know that the research associates will be meeting sometime this weekend to start dividing up the report and working on it. I will be sending out an email either later today or early tomorrow morning requesting for any final inputs on topics, whether it's changes or additions. Yeah, just wanted to put that on your radar.
Thank you.
Hopefully you won't be sending it.
Yeah.
There's a motion on the floor. Is there a second?
Second.
All in favor?
Aye.
Anybody opposed? Seeing none. Anybody abstaining? None. We're adjourned. Thank you. Thank you.